Have been talking about this issue of how we consume antibiotics, right? So there are people who just keep going for antibiotics every now and then, and there are people who go into an antibiotics dose, and before they finish the dose, they're like, I'm feeling better, so they stop it. And so there are issues with how then our bodies react. We have a new doctor in the studio. No, he's not actually freshly minted. We have a doctor who's never been here before.
Voila.
Dr. Mohammed Said is the hospital manager at Avenue Hospital, Parklands. He's our guest for the next 1 hour. City will welcome him with the day's proverb.
Yes. The hunter in pursuit of a lion does not stop to throw stones at birds. This proverb is from the country of Namibia.
The hunter in pursuit of a lion does not stop to throw stones at birds.
No.
Dr. Mohammed, karibu sana to Kenya's biggest conversation.
Thank you very much, Eric.
Mm-hmm. Now, this proverb, does it make sense to you?
Yeah, it does. I think I know of a particular quote that fits in a bit with that. I think it was Winston Churchill that says you won't get where you're going if you stop at every barking dog, yeah? So I think it kind of fits in with that. The African version had to involve a lion, yes.
Yeah. And birds.
Yes,
had to bring in
birds.
the beauty of the jungle,
Yeah.
you know? So, Dr. You are the hospital manager at Avenue Hospital in Parklands.
Yes.
Which one is it? This is the one in First Parklands, Avenue.
Yes, yes.
And you're here because we want to talk about frequent use of antibiotics and why we need to be concerned about this. Okay, so let's get straight into it. Why?
Yeah, Eric, I think first things first, I think people need to understand what antibiotics are in the first place, because without understanding that, it may not make sense why we need to conserve it. So antibiotics, these are medications that we give to fight infections, particularly bacterial infections. These are particular form of germs. I think almost everyone understands bacteria. So, okay, they are particular form of germs. Yeah. So this work by killing this bacteria, and so you get better. Why do we need to protect them? They're life-saving. Without them, it's safe to say half of the world's population probably will not be there, because that's what used to happen before they were invented, back in the 40s, 30s there. And they've been life-saving since. People are not dying from simple infections, like you get a wound and next thing you know you're, So it has revolutionized our lives. So it's something we need to hold dearly and not go back to those dark ages. The main reason why we should control we need to use antibiotics optimally and conserve them is what we call antibiotic resistance. And this is where these bacteria, these germs, are able to change, and to the point where the antibiotic no longer has an effect on them. Yeah, so it's basically giving nothing really against them, right? So the infection continues. We're not able to treat that. Yeah, and unfortunately, we're seeing that more and more. It's getting harder and harder to treat infections. I think recently there was some news around gonorrhea that was resistant to antibiotics. Super resistant and bug. Yes. So that's exactly, now imagine that happening for a number of common conditions that we have. Yeah. So that's really what we're most worried about. Yeah. So I guess that's the main concern.
That's the main concern. Yes.
Before we get to those that actually require a bacteria, rather require an antibiotic, does every bacterial infection require you to use antibiotics?
Good question. The answer is yes. Generally, by the time you get a bacterial infection, most of them will require, but yes, not all. Some of them are not particularly. How do I put it? There are some that, some small scrapes and here and there that can clear just by cleaning and all, yeah. But generally, yes. Generally, most bacterial infections require you to use antibiotics.
Okay.
Yes. The question really is determining, do you actually have the bacterial infection?
Exactly.
Yes.
So now, what are these bacterial infections that we speak of? A lot of times we make the mistake and say things like the common cold. We know it's not a bacterial infection. However, we have other things coming as a result. Tonsillitis.
Yes.
Children are going to school, they get tonsillitis, they come back, they get on an antibiotic for 7 days, 10 days, whatever. They go back to school, they get reinfected, you get on a course of antibiotics again. These are being prescribed by doctors. So you can find that in a month, 2 months, a child has been on 3 courses of antibiotics. Would you say then that is antibiotic abuse? Is that because you're being prescribed by a doctor?
It's a doctor
who's telling you this, and it's same doctor seeing this same child who gets the tonsillitis, has the common cold, but we know, okay, fine, antibiotics are not treating that virus because it's viral. However, the tonsillitis and all this other thing is being treated by antibiotics. Again, in 8 weeks, you've been on 3 courses.
So the first part, which is yes, there are infections that definitely require. As you mentioned, tonsillitis is one of the bacterial infections that require. But unfortunately, a lot of the times there's a lot of confusion between bacterial, what we call streptococcal infection of the throat. That's the commonest reason for the sore throat in terms of bacterial infections, and sore throats from viral. Yeah, and the sore throats from viral have similar symptoms, and a lot of times we get that confused and end up giving antibiotics. So whenever you see,
when you say we, that doctors.
Medics.
Yes.
Okay.
Yes. Generally as medics.
Okay.
And a lot of that has to do with the diagnostic capabilities. Yeah, because there are swabs you can do and quickly determine if this is bacterial or not, whether you need to give antibiotics or not. But generally, if you find yourself repeating a course of antibiotics, chances are either we're not treating a bacteria or we're not treating with the right antibiotic, because there's no like one single antibiotic that handles all kinds of infections. It has to be tailored. There's a best antibiotic for that particular infection. Yeah.
So reinfection is not causal here, especially amongst children whose immunity is not as built up.
Yeah, no, reinfections do happen, but when it happens that close together, chances are it's not a reinfection. It's just probably we haven't treated the previous infection properly, or it's a whole different kind of thing. Maybe the first one was bacterial, next one is viral, or vice versa. Yeah?
Okay. Yeah. Okay, I'm just, because I really want to get to, so in order for you to know as a medic that this particular infection is bacterial, what diagnostic process must you use? Must you draw blood? Must you use a swab and put it under, whatever? What must you do to establish that this is a bacterial infection before you now say, okay, fine, I will prescribe an antibiotic?
Yeah. So the what I'll say, like gold standard, the best way to determine that it's a bacterial infection is to do what we call a culture. All right. So it's where we take a swab, or if we're suspecting the infection is in blood, we take a blood culture. And so what I mean by culture is we take it to the lab and we grow the bacteria. We provide ideal circumstances for that, if any bacteria that's on that swab to grow. And once it grows, we're able to identify specifically which bacteria it is and go ahead and do what we call sensitivity analysis. Yeah, so we look at sensitivity testing. So we check it against the antibiotics that we have to see which one works best for this.
Sounds like it takes a minute.
Yeah, it does. So it take on average about 48 hours to get results. What we do in between that time is we give you what we call empirical therapy. Yeah? So there are some, because of your symptoms, how you've presented, we have a fairly good idea this is a likely bug that is causing it. So even as we wait, we're able to offer you something for those 48 hours. Yeah. But there are new techniques that are coming in, rapid testing at the bedside, where we're able to just check for the genetic material of the bacteria. So we do some rapid tests that can tell us if this bacteria is there or not. Yeah, and those ones you get within the day. Yeah.
Okay.
Yeah.
So should you, as a patient or the guardian of a patient, insist when you have been told we'll give you antibiotics when this diagnostic test has not taken place? Should you insist for the results of the test first? And because usually they'll say, okay, well, let's just give you antibiotics because we've looked at your throat, we've looked at your throat, just as an example, and then we say, okay, yeah, it looks like something I've seen before, so it must be bacteria, we're going to give you this. They've done your temperature, all of this. Or should you insist, no, actually, can we wait? Because we're talking about the misuse of antibiotics here, and it just seems to be the easy go-to thing when you see the symptoms, or I have a fever. So they say usually if you have a fever, it's a sign of infection, isn't it? Should you insist as a patient now on this test or on the results before you now accept to have the antibiotics prescribed?
Yeah, those will be dream patients. I think most of the time the opposite happens, in the sense that the patients pressure the doctor to
give
prescribe, because say, I don't have much time to wait on this, just hit it hard, provide everything, so that's really what normally happens. But to answer your question, the answer is you should definitely have a look at the results and have the culture done where possible. Where necessary, the doctor advises. But a lot of the times, the treatment may not wait. You may be, if it is truly a bacterial infection, a lot of the times you need the antibiotics. Yeah, so that's why we give that what I call the empirical therapy, as we wait for the results. Yeah, so that's necessary to keep you healthy. Yeah, to prevent the infection from continuing to progress while you're waiting for the results. Yeah.
Anecdotally speaking, an infection becomes a problem when you start feeling bad.
Yes.
So, as a layperson, how do I tell that this is a bacterial infection or a viral infection? Because
you're feeling bacteria
I'm feeling bad, and there's a bug.
Viral bugs.
Yes, virals, bugs, bacteria, bugs. So, how do I know?
Yeah, good question. So the bacterial infections tend to progress quite faster than most viral infections, and the symptoms tend to be quite severe generally, although sometimes it's difficult to really tell. But as doctors, we're able, from the history you give, how quickly the symptoms have moved, the presence of the temperature, how high the temperature is, the kind of symptoms you're having in the particular area, the radiological results, from an X-ray or an ultrasound or something else, seeing pus or things like that, it gives us a fairly good idea to know if it's viral or bacterial infection. Yeah. So, but as a patient, it may be difficult for you to. It takes that training for the doctor to kind of tell.
The reason why I ask is because there is a lot of self-medication that people gravitate towards.
Yes.
You Google search, and Google tells you that pain you have in your head is as a result of a throat ache. And then you Google search and say throat ache, medication, and it tells you some medication that ordinarily would kill a horse. So you go to the pharmacy and ask them, do you have this? Now, let me tell you where I'm going with this.
Yes.
whenever one visits a doctor, there's that process that you just mentioned where you're walked through. You tell the doctor what it is that's bothering you, how it's bothering you, when it's bothering you, etc., etc., etc. Is there a standard training for doctors where you are required to at least take a minimum of 5 minutes with your patient before you've understood what it is that is happening to them? Or syndromically, you take a look at them and say, in your mind, you're saying, this person, I think this one here, this one has this. So let them continue talking for 5 minutes.
This one's like the one who was here before.
Yes, exactly. Same. In fact, this one is even worse than the other one.
What I gave the other one times 2.
No, it is quite a process, and we go through several steps to determine the diagnosis. So the first part is obviously the interview, what we call the history, where we get as much information as possible, and that's where really the main clues come from. Really, it's from the history, from the interview. How it started, what is aching, who else was affected, what did you eat, where did you travel to. Like, there's so much that we pick up from that, and that gives us a good idea what is going on. Like, for example, you come in with a fever, you've just arrived from Bondo. I'll obviously think, okay, malaria is definitely part of this. So it's a careful thing that we take, and a lot of the times actually takes more than 5 minutes. I think on average about 10 minutes for particularly
including telling you to lie on that bed, and then they hit you in your stomach.
That's actually the second part.
The first part is this triage where you're taking your thing and all of this.
So the first part for the triage is just to see your vital signs. Basically, do you have a fever? Do you have a temperature? Is your heart rate elevated? All these things are clues towards an infection. And then obviously the interview, and as I said, that's really the critical part. And it's very important that you're pretty free with the doctor in terms of not withholding any information, because that could just change the because especially around sexual transmitted infections, people tend to be a bit coy about talking about them.
So they talk about the ear. My ear is itching.
Let's have a little bit of a deeper conversation about your ear. So now that you've opened that door, Daktari, so super gonorrhea has been splashed all over the place in Kenya and a couple of other countries actually on the continent. UTIs. And then we talk about the use of antibiotics. What's the story here?
So, some of these sexually transmitted infections and the bugs that are involved are almost unstoppable in terms of changing, in terms of them adapting to the antibiotics. Even when we use the antibiotics properly, sometimes this does still happen. So with the case for the gonorrhea, it's really not that new, because this bacteria has the particular bacteria that causes gonorrhea, Neisseria gonorrhea. It has adapted to many antibiotics before. So we've had to make these changes before. It's not the first time. And it's a particularly hardy bacteria that changes quickly. And actually the solution here is not to get it in the first place, safe sex, condoms, stuff like that, that actually prevents you from getting in the first place, because that preserves the antibiotics, right? There's no exposure to the antibiotics for this bacteria, because it's really not infecting people. That's really the best solution around it, but it's not something about just us misusing antibiotics. Unfortunately, the bug also is particularly hardy, and we are not the first country to be hit. I think 2015, I believe, CDC had an announcement around the US where they had this bug. So the best thing, the good thing about it is we have other ways to control it rather than just using antibiotics alone.
Let me ask this question. We were talking about treating it, curing it, but what about the idea of a prophylaxis for it?
A good question. This particular bug, we don't give prophylaxis.
Why?
As you said, it's pretty. It quickly changes to any antibiotics we expose it to. So the idea of providing it with more antibiotics as prophylaxis is really not. It's not ideal. And the good thing is, still majority of the gonorrhea bug out there, apart from this superbug that has emerged, it's not really widespread, thankfully. So it's a minority. So for the majority of people, still one shot antibiotic really solves the problem. Yeah. So one shot and it's cured. You don't have to take 10 days, 15 days. So still, for the majority of these infections, it's a one shot treatment. Yeah.
There's something that you mentioned here about when patients present and this interview process, that you'll find that maybe a patient is not very forthcoming with information, even if it's not sexually related. What mainly causes this?
Many factors. I think we come from different cultures. We have different beliefs around different symptoms. So sometimes not even the patient trying to hide. They just don't think it's relevant. Yeah. And it takes a lot of probing before the patient realizes, okay, this is useful information to the doctor. So there are cultural aspects to it. Some communities or some religions or some kind of group of people tend to be very protective around certain information, especially where that information is stigmatized or, has some social stigma attached to it. So people tend to be coy about it. But generally, as doctors, we try our best, sometimes over multiple interviews, to gain the confidence and, have a candid conversation with the patient, with a lot of probing and all. And sometimes you actually get back to the conversation after you have examined the patient, what you're explaining with the hand. The percussion. That's what it's called, percussion.
It's called percussion.
Yes.
You come and
Beating a drum.
what do you feel here?
So once from the physical exam, you could see something that you ask the patient, how did this particularly happen and whatnot, and sometimes that opens up. Or sometimes if you still suspect it as a doctor and you've ordered some particular test and they come back, and now you can have a conversation after you have the test. So different ways to get patients to open up. But by and large, at the end, most patients end up opening up. So, but it may take several.
It'll take a while.
It may take a while, yeah.
Sasa unajua mambo ni mengi, masaa ndio machache bana. Kuja sema shida yako uende. Watu ni wengi kwa line. Let's take a break. 9:30. Dr. Mohammed Said is the hospital manager at Avenue Hospital Parklands. We are talking about frequent use of antibiotics and why we should be wary of that. What are the effects of using antibiotics?
This is the Situation Room, the only way to start your day.
With Dr. Mohammed Said from Avenue Hospital in Parklands, talking about use and misuse of antibiotics. Dr. So for a greater part, you will walk into a health facility and the medic will give you a prescription. Or, like Sikti was saying, you'll self-diagnose using Dr. Google, and you'll see this is the medicine to go for, and you'll not go to the market to buy it. It will not be sold by Mamboga. You'll walk into a pharmacy to buy it, where you'll find somebody else who should be trained on dispensing medicine. So in both these cases, the higher percentage of likelihood is that you're actually getting medicine from the hand of a trained person who gives you these antibiotics. So the issue of then misuse of antibiotics, should we not be addressing you people instead of you addressing us?
Very true. I think I'll get to from a patient side, what you can do from a person who feels they require the antibiotic. But you're very right, Eric. The bigger impetus lies with the healthcare professionals. And we have what we call antibiotic stewardship programs running at a country level and at a global level also, but also at facility levels. So to address the issue around pharmacies issuing antibiotics, so the World Health Organization classifies the antibiotics into 3 groups. So what they call the access group, where these are antibiotics that are okay with just a prescription you can get, not necessarily over the counter, but with a prescription from the pharmacy. Yeah, so you don't necessarily have to go through you don't have to see a specialist for it. All right. Then there are those that we call watch group. Yeah, and these ones should be given with a lot of care, and you must have test results and whatnot. The other group, you could potentially, just based on the interview and the examination findings, we could provide you with that antibiotic. But these other ones, we really need you to go through some testing. We know which bag it is, if we're actually giving you the correct dose and the correct antibiotic. Then there's what we call restricted antibiotics. So these ones should not be used at all without the input of a specialist with particular training on infectious diseases and how to use these antibiotics. Yeah, so it needs a pre-authorization for you to use that, and their use is highly controlled. So that's the ideal situation from a policy perspective that needs to happen. We do have, fortunately in Kenya, we do have those policies. The implementation may not be 100%, but we do have those policies, just need a bit of strengthening and all. But these are WHO standards that are set, and countries are to adopt in terms of, we call it antibiotic stewardships. As the word stewardship from the English means, something you've been entrusted with to take care for the next generation, sort of like forests. Yeah. So it's a concept like that. So basically to control that use. Yeah. Is it working 100% in Kenya? Unfortunately, no. We do have rooms for improvement, such that there are pharmacies that would issue antibiotics without a prescription and things like that. Those situations do still happen. But from a policy perspective, we have a policy that controls that, restricts that, so that you don't get access to antibiotics that you shouldn't be accessing. But also what is happening is the diagnostic capacity to test, because that was the other thing that was restricting us. I mean, I said for you to get access to these watch agents or the restricted ones, you need to have a thorough testing. What I described about the culture, unfortunately, that's not widely available across the country. We're still a developing nation, and that has been a hindrance. So a lot of times the doctors have no option but to just give you the medication because they don't have access to those testing capacities. But again, fortunately, it's an area where we are growing rapidly, at least in the private sector, where most hospitals now have the capacity to test for these bugs and which antibiotics go with it. So that capacity is growing. So from a policy perspective, we're okay. It's work in progress. Let me put it that way. So there is that antibiotic stewardship that is broad. That is helping us keep these antibiotics safe from our end, right? So, and at the hospital level, because this is where now the high-end antibiotics, what you'll call the reserve, the last resort antibiotics, are prescribed. It's at the hospital. This is where those specialists work. Right. And at the hospitals now, there are strict policies who can prescribe, for how long, which drug you can prescribe, and you must have a culture. There's a lot of that happening within hospitals.
Both private and public.
Depending on the level of the hospital, the capacity of the hospitals, but by and large, most big private hospitals and the major public hospitals, these are things that are standard, that are done to protect antibiotics. So there's a lot of effort from that antibiotic stewardship from our end, from the healthcare fraternity to protect these antibiotics.
Just going with that, from your own observation and having talked to fellow medics, what are the greater causes of antibiotic misuse? Is it that self-diagnosis led somebody into a pharmacy and then they took the antibiotics, or is it the original source of the antibiotic was from a medic?
Difficult to say where to put the blame, but I think the bigger issue is it needs concerted effort. Yeah, it's not really about who's particularly responsible, more about what can we do as every party, because there's a part for each person to do. You as a patient, there's a part you need to do, and I'll get to that. And there's a part we have to do as a healthcare fraternity. Yeah. So as I mentioned, the antibiotic stewardship, that's something that is growing in the country. There is funding for it coming from donor organizations, but also internally from the government and all.
To champion this.
To champion this. Yeah.
You know, I'm asking that. It's not actually for placing blame.
Yes.
It is for identifying what the main areas of concern would be. Where I'm going with this is many people, when they go in front of a medic, they entrust the medic with everything. So I don't question. I mean, medic just scribbles things I can't read, and I trust that whatever information I give the medic, they are able to diagnose something, and whatever medicine that they're prescribing for me is good enough. So we have that culture of we trust the healthcare provider.
Yes.
Now, if we are seeing this serious proliferation of misuse of antibiotics, is it because of placing too much trust on the healthcare provider that we should be asking questions? Is it because the healthcare provider is actually doing the best that they could, but they lack the proper diagnostic capacity?
Yes.
What exactly is it? So where should we be focusing our attention?
No, I think our attention largely needs more investment into this, what I describe as antibiotic stewardship, and supporting that diagnostic support. Yeah, like a colleague asked about the results taking too long. Yeah, so having those rapid diagnostics available to almost everywhere. Yeah, basically able to get that quickly, even at your local pharmacy. Yeah, so you have that quick test, and we're able to know if this, you should be able to get this and all. So Eric, I'll say the biggest effort should go into this antibiotic stewardship. So more funding, more strengthening of the systems. That's where we'll get the biggest impact, right? Yeah.
You know, I'm deep in thought because I'm thinking this. I look at other disciplines. I look at other professions. I look at other businesses, and I look at the amount of time and effort that is put into getting the potential clients to understand the nature of the business and how it would benefit them. I see in the advertising space, health facilities, hospitals, talking about what it is that they provide. Now, what I don't see is how it is the medical profession is explained to the would-be consumer of the services as to how it is that that particular profession interfaces with the health needs. Meaning, I look at, say, for instance, banks. They're in your face about it. I look at people who are in the manufacturing business. They're in your face about it. And yet, this is an aspect, a discipline that cuts to the core of not our livelihood, our lives. And the people who are involved seem to be content to let us go to them instead of them telling us, so that by the time I'm coming to you, I'm better informed by the time I'm coming to you.
Agreed, Seti. And that's why I'm here. Yeah, to share as much as possible. Yeah, but there's so much. You're right. It's a sensitive area in our lives. Our health, our wealth is our everything, and the more we know about it, the better. And I think on that front, there's been a lot of improvement. I mean, as I said, one of the things is my first radio talk here, but there's a lot of patient advocacy, self-management learning. Like if you're diabetic, you're taught how to test yourself, how to do. So there's a lot of growth in that as well, and a lot more available information than ever before. Yeah, you go to any hospital's website, or you get to WebMD or whatever it is on the internet. So there's a lot more information available. But I agree, we need to do more to educate the patients.
What are the effects of frequent use of antibiotics?
So the first one I mentioned was the antibiotic resistance, where now we could lose potentially very useful antibiotics today that may become obsolete, cannot use them anymore, they are no longer effective. So that's the biggest danger that we're really worried about, and hence why the policies around antibiotic stewardship really need to be strengthened, and diagnostics and all this need to be empowered, and the patients also have their part to play. But the second other thing is, remember, antibiotics are medications at the end of the day. They do have side effects. And some of the side effects are the usual, you could get the nausea, vomiting, diarrhea. You could get all this kind of effects from the antibiotics. And also the allergies to antibiotics are common, relatively common. And that you could get an allergy out from that antibiotic. Then also taking antibiotics unnecessarily affects your what we call let me use normal flora. What we mean by that is on our skins, on our intestine, in our intestines, all this, we do have bugs that live there, and we have a symbiotic relationship. Like good bugs.
Yeah.
We work. They help us digest food.
Yeah.
They help us fight off the bad bugs. So we have a relationship with them. It's something unique to you, because it's the bugs you pick up from childhood, from what you've been eating, where you've been living, the water you've been drinking. So it's bugs that are all around.
So your
us.
bugs are not like my bugs.
Yeah.
Okay.
At a high level, yes, they're similar, but when you go to the nitty-gritties, there are some differences.
So you're saying bugs have specializations?
Yes. And now what happens with antibiotics is you get rid of also those good bugs, good bugs in quotes. So you get rid of those ones, and now their place is taken up. For example, I think this commonly happens to ladies more often. You take antibiotics for, let's say, urine tract infection or something like that, and next thing you know, you're having a yeast infection, a discharge caused by yeast infection. And this because you got rid of the good antibiotics that will have prevented that yeast from growing, right? So the use of antibiotics is not completely harm-free. There is some harm.
So what do you do in that case? I mean, because if this thing, which is supposed
you look for your good bacteria.
What do you do? Give me back my good bug. What are you supposed to do in that case if you have a potentially threatening infection that you must treat with antibiotics, but then at the same time it poses a risk to getting rid of your good bugs, as we're going to call them for purposes of this discussion? What are you supposed to do?
Yeah, and hence why the use of antibiotics has to be very optimized. So we have to really go through a rigorous process of knowing exactly, do you actually have the bacterial infection such that you'll benefit from this antibiotic? Yes. Then we do choose the best possible antibiotic for the shortest duration with the least amount of side effects to you. So that's what we go through. So in that case, you have more to benefit from getting the antibiotic than the risk that are involved.
I have to ask you.
Yes.
So let's look at this UTI just as an example here, so we can break down this thing.
Yeah.
So are you saying that the medic who then is treating this person is really thinking those three things that you've said?
Yeah.
Trying to make sure that we give you an antibiotic that you use for the least possible time, that will have the least effect, and then get you, or are you just trying to zap this thing without thinking about those three things that you've mentioned?
No, we do think through that, because at the end of the day, medicine therapy is about risk benefits.
Okay.
We must be sure that what you're getting more benefit from this treatment than any potential harms. And the good news about it is the this normal flora, the good bugs, they come back after the antibiotics wash out. They grow back. They are restored back. Yeah. So and hence why you shouldn't take antibiotics unnecessarily. Yeah, because each time you take, you're wiping them out, and they need time to grow back again. Yeah, and recover. Yeah.
So then sorry.
No, please.
Second time.
No, please.
So it sounds, so when you say don't take, and that's the thing, when you say don't take antibiotics regularly, it seems as though sometimes you cannot help but to, because if you have the infection. But then I hear you saying, maybe without having said it, that then there are certain things you can do to avoid getting these infections in the first place that would lead to you getting the
exactly.
Such as
hand washing, just to start with, common hygiene thing. And for sexually transmitted infections, I think we discussed that. Again, prevention against that. Abstinence, yeah, ideally, if possible. Then, so there are those preventive measures, all right? And then also it's about being, if you need to take, now I think we can come to what the patients need to do. So number one, please take as directed. Take the antibiotics as directed. A lot of people will start, they feel better, they stop. Then now the bug resurges, and by that time it has adapted to that antibiotic. Now it's a super bug. So finish your dose properly as directed. Don't skip doses. If it's causing you any side effect or anything, please reach out to your doctor, your nurse, your health facility, and they should be able to guide you way forward. Yeah. Then the other thing is, do not use someone else's antibiotics. I think that's a lot of people say, it's a really common problem.
Yeah, it's a very common problem.
This, it works.
Yes.
Yeah, so you have a few left. People who didn't finish theirs have some left, so you come to my house and then you say, can I borrow?
Exactly. So don't use someone else's antibiotics, because you may not be having the same infection, and or you may not actually be having an infection that requires that antibiotic. So that's the second thing. And then the third thing, I think, is something you mentioned. If all patients could be like you, don't pressure the doctor to give you that, because sometimes, as a doctor, you don't want to know your patient either. So if the patient insists on it, you prescribe. Or the mother insists that, okay, that's for pediatrics. I'm an adult doctor, but I see that for pediatrics, the mother or the father, the guardian insists, okay, I don't want this kid not to sleep tonight. Please just zap this thing. So I think that is also something you can prevent and doing. And the preventive measures that we talked about. So that you doing that really helps in reducing the use of antibiotics, so that you're only using them when you do need them, and therefore preserving their efficacy over time.
City?
Yes, please.
Now is your turn.
Every time I think of the word antibiotics, my mind goes back to Alexander Fleming. How he accidentally discovered penicillin, because it was accidental, really. But it's odd about very many major inventions. They're accidental. One starts pursuing a certain goal, and what they end up with something completely different. But this discussion about antibiotics, it seems to go toe in toe with the discussion around opioids. Okay, something that is intended to be useful, and yet somehow the abuse of this very same thing now seems to cause more harm than probably in the disease for which you are taking it. Beyond the ABC of prevention, abstain if it's sexual matters, use a condom, use something else, take a cold bath. Oh, no. Whatever it is.
I hope no one said that.
I don't endorse that.
The need to actually have people understand, there's this little piece of paper every time you buy medication. I think it's deliberately in small print. I call it microscopic. where they tell you the whole story of what it is you're taking, plus what they call the contraindications.
With very long words of logical and logical.
Yes, and don't take this at night. And if it's you must take it at night,
Don't operate heavy machinery.
or the moon must be out before you take it. You know those sort of things. Now, is it possible for the medical fraternity to work with the pharmaceutical industry to make this thing a little simpler to understand? Because
Bigger font.
yes, exactly, and
text.
simplify it. Say,
3-letter
you see why
words.
I'm saying this
Less
is,
text.
is because that documentation seems to, the purpose is intended for
It's like targeting the dispenser.
and indemnifying the
consumer.
pharmaceutical company, meaning
Yes.
they're telling you, we told you. That thing, my friend, is a publication. It's not just a small document. But when you read it, it's very informative. I'm saying, in your quest to get the potential patient or client or the citizenry to understand these things, if that thing was simplified, some of these problems we're talking
To
about,
make it easier.
it would be at your...
Doctor, is it possible
yes.
to champion for
it
this?
is possible, but you have to understand from the pharmaceutical and the innovators' perspective, the manufacturers, they have to go through a rigorous
It's okay.
process.
We understand.
Yes.
They can do that.
We've got that.
Can they also do like an abridged, adamified
yes.
version?
Synopsis.
Yes. No, there is.
Okay.
There are. Just not inserted with the antibiotic, but for certain particular antibiotics, we do give a pamphlet that allows
That-
you to
that explains.
get that explained. Yeah.
Okay. Dr. Thank you very much. Like you said, this is a beginning of very many conversations to continue having on things that are happening. We wish you a lovely weekend.
Thank you very much. You too. It's been a
We will
pleasure.
come visit you at your hospital, not when we are ill.
Yes.
You're welcome. See all those things.
Yeah.
Dr. Mohammed Said is the hospital manager at Avenue Hospital, First Parklands.